contact, then you have the passive eruption, which is the apical migration of the gingival tissue until accommodation on or very close to the cement enamel junction, determining the gingival margin position. So most of the time, when you have a problem with altered passive eruption, this is what's going on. But this is only when the gum tissue is not there. So the classification that we have been using the most is one from Coslet in I think it was 67. So it's a very old article, and basically he was classifying in type 1, which is when you have an excessive amount of gingiva, and in the type 1 you have the A, which is normal crest to CAJ relationship. So the bone is at the normal distance from the CJ, which is considered 1.5 millimeters. And in type B, actually the bone is very close to the CJ or even over the CJ. So what happens here? In this type, you have to do osteoresective surgery. In this case, you only have to do the gingivectomy. And
we can understand this with bone sounding.
Bone sounding, yeah. Exactly. This is very important. So when you're starting to treat the patient and the patient is numb, you do bone sounding. So you push very hard until you feel the bone, and then at that point you kind of have a higher sense of where it is. Then in type 2, you have a normal amount of gingiva, and in the A type, the bone relationship is normal, but you cannot do gingivectomy here, because if you cut this gingiva, you don't have enough attached gingiva anymore. So in this case, you do gingivectomy. In this case, you do apically position flap. In both these cases, you have to do osteoresective surgery. But in this case, you can do gingivectomy and also resective surgery. In this case, you have to do apical position flap plus osteoresective surgery on the area. Now, they only talked about altered passive eruption, which supposedly is not 100% correct. So in this month's issue, in the July issue of the CAP, which is the other journal from the American Academy of Periodontology, there has been a new study. It's the first study after 67, so it's 50 years later, from a Brazilian group, which kind of repeat the same thing, but with a more proper terminology. And they say if you have altered passive eruption alone, then basically the bone is always at the same level. So you have type 1A and type 2B, which is pretty much the same as before. And in altered passive eruption with altered active eruption, so you have an alteration of both processes, then in this case you always have the bone closer to the cement enamel junction. So you know that in these cases you have to do osteoresective surgery. So basically it's just the same as before. In altered passive eruption alone and type 1, you can do an external bevel incision or internal bevel incision, gingivectomy basically. When do you do external bevel and when do you do internal bevel? Well, basically, it's your choice. The thickness of the tissue is one of the things that you want to look at. If it's very thin, you want to go with an external bevel, most likely. In altered passive eruption alone with type 2, so with little gingiva, you can only do internal bevel incision and apical position flap. Is it okay? Yeah. It's similar as before. Mm-hmm. Okay. If you have altered passive eruption plus altered active eruption, you have to do an internal bevel incision and also resective surgery. You cannot do external bevel because you want to remove bone. Mm-hmm. So you can't do external bevel gingivectomy.
If we don't remove bone, it will grow back the...
Exactly. It will grow back and it will not heal nicely. And in altered passive eruption plus altered active eruption in type 2, you do the internal bevel incision, you do the apical position flap, or osteoresective surgery. OR means osteoresective.
And in these cases, how we decide how much to... Do you reflect the whole flap, or you are just
if you have
separating
to-
the tissues.
If in this case, you do your paramarginal incisions, and you do them on the basis of your of the length of the tooth that you decided with the lab technician or the prosthodontist. So you mark where the tooth has to finish, basically. Then you only elevate a little bit and you remove the bone, or you use a sonic instrument to remove the bone and make it far away from the CJ. And far away means at least 1.5 millimeters. That's the accurate number that you have to have at least that number. Then in this case you have to do an apical position flap because you don't have enough attached gingiva. So if you don't have enough attached gingiva, you basically do a split thickness and you reposition it over it. So this is a more advanced surgery because you're going to have to do a larger flap, position it apically, do the